Thank you for the opportunity. So I'm going to talk on our device-based iStent versus a non-device-based bang. It's basically comparing an economical device versus very cost-effective one. So mix is something that is very promising for the mild to moderate POAGs, and we have a cost-effective modality which is a 25 to 26 gauge needle which we use for a bent ab inteno needle goniectomy. And then there is the costlier version or the higher economical version of the iStent which has three different versions as well. So most of the purpose of the study was to evaluate mild to moderate POAGs who are currently under treatment with anti-glaucoma medication and with cataract. And these are the primary outcomes: reduction in IOP from baseline, reduction in the AGMs, and how many bottles were reduced and how many percentage were medication free. And the secondary outcomes were complete and qualified success with failure and complication profile. So the World Glaucoma guidelines were followed for complete qualified success as well as for failure. And this was a prospective study, and for a 6-month period, the patients from March to October 2023 were taken, and these patients were followed up for another 6 months, and 64 patients were enrolled in this study. So based on the visual field, they were taken as mild to moderate. It could be Humphrey or Octopus on two separate visual fields that were done. And the study design based on logistics especially and personal preferences, 31 patients opted for bang, 20 for iStent and 13 for iStent inject. So this was an open label study with both the patients and the surgeons being aware. And you can see 1 week, 1 month, 3 months and 6 months for the follow-up with gonioscopy and anterior imaging also being done. So this is the procedure in a nutshell: a 26 gauge needle which was used to excise, which is the cost effective version of MIGS. And then we have the generational 1 device which is obsolete now, and then we have the generational 2 which is the iStent inject, where you actually place axially you place the stent rather than a tangential one. So pair t-test was used for analysis with a p-value of 0.05 being significant. So the phaco bang analysis, you can see the IOP from 20.28, at the end it's around 15.01 with the bottle reduction of 1.07 to 0.49, and these are the greater than 1 AGM and medication free percentage, and the complete success and a qualified success along with of 74 percentage. In the phaco iStent analysis, since it was only a single stent from 21 to 18.69, but the number of medications you can see from 1.82 to 0.36, and again these are the greater than 1 bottle reduction and the medication free with a complete success rate of 80 percentage. And the phaco iStent inject group analysis from 22 you can see to 15, and then here there was a catch for AGMs were 2.07 to 1.43. And then let's see a comparative analysis, and this has around 85% success rate. So in a summary, if you see the three modalities, you can see that bang and iStent, we were all more or less the same in terms of the pressures, but iStent, if you see, that was able to reduce only up to 2.81, whereas the other two were up to 6 and 5.27, whereas the AGM reduction was slightly lesser in terms of iStent inject, which was only 1.43. The greater than 1 AGM bottle reduction was more or less the same, but iStent inject had only 73 percentage and bang had only 50 percentage of them being medication free at the end of the study. So this is how it looks, where the failure rate, if you see, if you order it in terms of failure rate, iStent inject is slightly superior to iStent, as well as then comes the bent ab inteno needle goniectomy. These are the demographics. There are a few complications with the incisional procedure, and in iStent inject as well. Sometimes you may have few patients with choroidal folds. One of my cases had because of a mild incision that was slightly wrong. And then there is a PAS in one of my iStent cases where we used the YAG laser to release it up, and one patient had urate zavalia. So these are some of the animations that shows the procedure. Again, it's an excision one, whereas iStent is more of an incisional procedure, stenting procedure. They reduce the IOP, and each one are equally good in their own way, but the catch here again is the complication profile, which is much better, and the failure rate is higher in the bang group. If you see here, the total success, iStent seems to be much better than the bent ab inteno needle goniectomy, and among the modalities assessed, iStent inject group demonstrated most significant reduction in IOP, particularly in terms of lower complication profile. However, it's less economically viable with more AGMs which may be needed in the post-op. Though they both produced comparable IOP and AGM reductions, one being an excisional procedure which is instrument not made for that, the failure rate appears to be higher in those group. So there are some limitations. We need more RCTs. Thank you for the opportunity to present this data. Thank you.
Very good presentation. Any questions from the audience? Dr. Venkatesh, what is your post-op regime?
So the post-op regime, I follow a similar one to the cataract, sir. I give steroids and antibiotic. If there are a reason for a pilocarpine, then I definitely do give, sir, pilocarpine, especially if IFEMA is not there in those patients.
We have seen there is a post-op high, post-op spike, like steroid response if we use more than steroid for more than 1 month.
Sir, I don't do it for 1 month. I do it in a short course and then taper it quickly along with an NSAID and a cover. And another thing about the pilo also, only if an IFEMA is there, then I won't do it. And that's how I go with my post-op regimen. And IOP drops, I stop it, sir. I don't continue with the AGM medication. And I see the post-op week 7 days. And if needed, I'll then add the AGM. So I stop my AGM, all AGMs involved in the pre-operative. If there are 2 or 3, I stop all the AGM.
For how much time NSAID?
Yeah. NSAID for another 3 weeks, sir. Not more than that.
Just one
yes, ma'am.
thing. Now, the sample size, if you look at this thing is pretty small.
Yes, ma'am.
So, do you think you can conclude saying that the iStent inject had better success outcome than iStent, and is there any statistical way that you can say that it is significant?
Ma'am, it's a very tricky scenario because iStent inject, the number of AGM was higher compared to the bang group. So from 2 bottles, it was more like 1.2 or 1.4. So whereas bang had a good number of reduction in AGM. So what I personally feel is we need to involve more studies like Suchagat as well as the KDB and then do a complete RCT to understand where we stand, at least in the mixed journey.
Even in this data, rather than involving more, we need more numbers to actually say, because 7 and 15, the comparison like that, it is hard to say.
Yes, ma'am. The stenting devices were little less, ma'am. Yeah.
What I suggest is do in one eye do bang and another eye iStent. We have done this. And iStent results are definitely better.
Yes, sir. Thank you, sir.
And have you done W model?
Yes, sir. W is also something that we have started since last September. The flanges of it are definitely much bigger, and the over implantation is avoided with inject W. With another thing that I noticed with W was the trocar bias. In the iStent inject, there was more trocar bias because the threading of the needle was slightly in the front. But with W, they have made sure that the hollow encompasses the needle of injection. So the trocar bias is something that is not happening, and over implantation is also not that much with W.
Any comments on the right sided iStent, the basic model?
Which one? The
one you showed was the left side.
Sir, I have no experience with the injection of the left-sided one. Yeah, I have no experience with that, sir.
Sorry, last one.
Yes, sir.
Difference, did you study the difference between iStent versus iStent inject?
Yes, sir. So that was also part of this where I compared the 3 together. Definitely the volume of intraocular pressure lowering is double that of inject that we see, because 2.8 was in terms of millimeters, whereas with inject we got up to 5 to 6 millimeters. So definitely with 2 stents, that's the way forward. Maybe if Infinite is going to come, I think we'll have a much more armamentarium where 3 is going to be in place.
So the message is we should not try the iStent.
So message is every surgery is there. Each one has its own plus and minus, sir. Whereas bang will also have its role, is what I strongly presume. Excisional also has its role along with stenting devices. Yeah.
Very good. Very good.
Thank you, sir.